Hello, and welcome to today's webinar event powered by Vine Medical. Vine Medical has the pleasure of hosting today's webinar event titled How to Establish Thoughtful Access to Care with Chelsea Bodnar, Kate Lufkin, and April Malan. We will begin this event moderated by Vine Medical's product manager, Mike Else, shortly. Afterwards, we will have a no-holds-barred Q&A session. We may not have the opportunity to address all questions during the presentation, but please feel free to ask any questions in the question section of the platform, and we will get to as many as we can during the Q&A at the end of the session. This webinar is being recorded, and when the live webinar concludes, our system prepares an email to be sent to the email address that you registered with. We know that a lot of you would like the other members of your staff to be able to watch the webinar, so please rest assured that it is recorded and sent as a follow-up. Thank you.
Awesome. Thank you very much, Jen. As Jen said, I'm Mike Else, product manager here at Vine Medical. I manage a product that is focused on care coordination, telehealth, other things of that nature, but pretty much mostly about interacting with patients directly, which is kind of new for Vine Medical. Today, we're talking with our friends here at Montana Pediatrics, who were basically the inventors of that and of that concept. And so we're very familiar with each other, and I'm really excited to be here today to hear them tell everything they've ever told me to you today. So a few of the things that we're going to be talking about in general is exploring how a perceived increase in access to healthcare can result in a decrease in overall health. Also to discuss how a lack of access to healthcare is a challenge for patients in both rural and urban settings, and how a successful partnership between healthcare systems and thoughtful access can help. And then also to highlight how healthcare systems can relieve the burden of communication from families. So those are the things we're going to cover. I'm very excited to do so today. I'd like to also give a little bit beefier of an introduction to each of our panelists today. First is Chelsea Bodnar, who's the Chief Executive Officer of Montana Pediatrics. Her career is focused on improving the quality of primary care for children, hence Montana Pediatrics. She served as a health policy fellow at the Institute of Medicine, a director of children's healthcare quality at a large consortium of federally qualified healthcare centers, or FQHCs, also a primary care physician for children in a wide range of care settings. She's got experience in the use of technology to improve screening rates for high-risk children and leading the creation of a specific telemedicine platform. She's also served on the executive committee for the American Academy of Pediatrics, specifically the section of telemedicine for 6 years now. Is a fellow of the Robert Wood Johnson Foundation and a leadership fellow with the American Academy of Pediatrics, a presidential scholar at Harvard Medical School, a Rhodes Scholar at the University of Oxford, and received her BA from Montana State University, Bozeman. Hi, Chelsea. Thanks for being here. It all needs to be said. Quite decorated. And additionally, Kate Lufkin, the Chief Communications Officer for Montana Pediatrics, 15 years of outreach and program development expertise for the Montana Pediatrics team. She's developed a passion for identifying community-based challenges and bringing siloed organizations and individuals together to work collaboratively toward unique solutions. Most of Kate's work is focused on developing and initiating numerous multi-channel outreach campaigns while maintaining communications oversight in the conformance with Montana Pediatrics goals. She's also been named one of Northwest Montana's 20 under 40 award recipients, and prior to her role with Montana Pediatrics was named a 40 under 40 award recipient by the Association of Chamber of Commerce Professionals. So also, Kate, thanks for being here today. And certainly last but not least, April Malan, who's the Chief Operations Officer. Is a wealth of rural healthcare operations experience. She started as a clinical microbiologist and operations leader, where she worked alongside rural providers and larger tertiary care centers for patients living within remote areas. Her career focus is to improve healthcare access to all patients while leveraging technology, relationships, and improvement in logistical footprints across Montana. April is also a member of the American College of Clinical Pathologists and attended George Washington University. So those are the three of our friends here today. So thank you all again for being here. It's really exciting. So to jump right in, perhaps a fun intended but yet vague question. Please tell us a little bit more about Montana Pediatrics and its inception and its goals today.
I think that's me. Do I go? I've been at this for the longest of this crew. Thanks, Mike. I just want to say how much we enjoy working with Mike and how grateful we are to be here, and that he has heard us go in great depth on all of these conversations. And there's not a lot of folks who are operating as product managers out there in the technology world who get this much time with these types of concepts. So we're super grateful for that and for our relationship with him. So Montana Pediatrics started off with a couple of sort of proactive objectives and some objectives that related to sort of defensive moves in the market as well. So telemedicine, back before, as we would say, BC, before COVID, was really being disseminated in the world primarily as a technology first model. So there were this concept of, oh my gosh, doctors can video conference too. And if you can video conference and you're a doctor, then you could do healthcare. But change in healthcare is really hard. And so the initial models were really more about this idea that we could just create a cloud-based model of healthcare that we would beam in sort of indiscriminately across the country. And when you are an organization who's primarily focused on scale, which is the technology sort of holy grail, you kind of have to treat your doctors in any doctor will do kind of way. You have to be as non-specific as possible. And this was a really concerning set of trends for people whose primary focus in the world was on high quality, highly specific, pediatric specific, the best healthcare for children, which is necessarily contextualized. It's also necessarily requires a specific set of knowledge. So Montana Pediatrics, which now Montana Pediatrics, was born out of this idea that rather than competing with the existing healthcare infrastructure or displacing it or disrupting it in a way that would potentially increase fragmentation or threaten rural practitioners or fragment the market, we should take the lessons of telemedicine, of access, of convenience, and think about it as a buy with and through model. We should tackle working with our pediatric providers to give them the capacity to work together. Early on, there were fewer telemedicine platforms out there, and there was certainly no one who was thinking of telemedicine as a fundamentally collaborative model, in which it wasn't just about how does a patient connect to a doctor, it was about how do doctors connect to one another in a new way that could be a solution for our impending primary care crises, and that was supportive of the isolated rural practitioner or even supportive of the small health system. So Montana Pediatrics is fundamentally there to increase access to care for children, but not just any access. Not all doctors on the other end of a video screen count as access, and the data is really clear on that. It's high quality access. It's access that's going to continue to support your local healthcare ecosystem so that we have a click and mortar future. And it is access that is deserving of the incredible amount of trust that any caregiver needs to have in their moment of need around their child's health. These are doctors. This network, this system allows people to really make a different decision. They don't have to go to the emergency room because they know that who they're getting gets them, knows their child, knows their community, and will treat their child in the highest quality way. That's a really long answer, but I think that's where we came from and where we are. Kate and April will give the much more succinct versions of these answers. Oh, I can't hear Mike. Is that me or is that, oh, okay.
Can you hear me now?
You're back.
Okay, sorry, I forgot I was muted. So given the circumstances of how and when and why Montana Pediatrics was put together, it seems like one of the things that we've talked a lot about, and frankly is a significant contributor to what dictates my day-to-day in working with Montana Pediatrics, is some of the specifics around dealing with things like after-hours care, or just general complex care coordination. And geographic isolation as well. Could you talk a little bit about those specifics and the approaches that you wanted to take, also contrasted with the solutions that you've seen in the past, assuming there were any?
Yeah, so I can kind of take those bit by bit. So after hours care is one of those moments in healthcare where everybody's losing, right? So when healthcare is a beast to try to make change, because as you know, you have providers who have a very highly specialized set of skills, you have patients who absolutely deserve access to the best, but then the market forces that actually mediate whether anyone can afford to have that interaction, either get paid or pay for it, is an insurance company or a government insurance company who have, so it's a three-legged stool anytime you're trying to innovate in healthcare. It's really hard because you need all of those folks to benefit or perceive they will benefit or sacrifice in order for the good. So after hours was a great place to start for us, because after hours was a big pain for everyone who has to believe. So in Montana, we looked and said, all right, what's happening, and nationally, what's happening after hours? It stinks to be what's the worst time to be a primary care doctor? Midnight, when someone's worried about a rash on their kid and they have to work tomorrow and you have said you will be available, which is the right thing to do. And so you sleep on the couch because your spouse doesn't want to deal with it anymore. And you're going to get 2 phone calls that you're not going to get paid for. And by the way, it's kind of crappy medicine. We know that the most kind of dangerous from a litigation perspective interaction that a physician will have often comes with just those like one-off phone calls in the evening. So stinks to be a doctor. Really stinks to be a parent though, right? Let's keep that at the forefront. You're home, you've got a kid, you're worried, you get paid by the hour, you have work tomorrow, you don't know whether you can take your kid to school, your whole life is going to be turned upside down. And not to mention, you're staring at the human you love most in the world, and you're watching that breathing and you're saying, what do I do? Right? And you know that, and you may have another kid who's asleep and you may be the only one at home. And it's a pretty high stakes moment to decide how much to worry and what actions to take. And then we have the folks who also matter, which is the payer, and they're also in that moment of after hours. And what do they see? They see a new parent who probably everything is fine. Why didn't they just stay home? Loading up their child and heading to an emergency room that you can't walk through the front door for less than $1,000 to be given the advice that everything is fine. So we started with after hours because it was a place where we could sort of say, it sucks to be a family, it sucks to be a doctor, and it sucks to be a payer. And if you can get everyone to agree that that moment is one that is not functioning well, then you might have the opportunity to move towards a big and important solution on your hands. So Montana Pediatrics started with a collaborative model of 15 amazing early adopter pediatricians who said, we already feel we're overworked and underpaid, but we want to be more present for our patients. And we see this collaborative model as a potential solution for ourselves and our colleagues. So after hours telemedicine requires the grouping of the physicians at night. They share call. The platform allows us to seamlessly schedule who's going to be on, to route those calls, to do all the documentation, essentially to be an entire front desk, an entire scheduling system, almost an entire practice, without any humans being involved other than the patient who shows up and the provider who provides the care. Once we got that going, though, we realized, shoot, if you can get providers from disparate systems to work together in a complementary manner to the work that they do locally, in the service of patients, and always mindful of the fact that we need to build efficiencies into our healthcare system, these other opportunities came up. So what does it look like? Where better to do care coordination than in a collaborative cloud-based model that everyone can access when they need it, at the time they need it, that transcends technological and administrative boundaries? So that became a really important one. We also realized, heck, if a provider can sit in the comfort of their own home and serve a patient, we can be present in the places no one has been willing to be present. So we can be in a homeless shelter at midnight. We can be in a school on a remote Native American reservation all day long. And we can do it in a way that doesn't ask a level of sacrifice of providers that has become so unrealistic that those places just are unserved otherwise. So we've gone from after hours as an important place to start to build the community to this realization that if we can build the community and the functionality is available, there's many, many more places where this model of medicine serves communities who otherwise aren't served, or serves purposes in healthcare that have been vexing as long as we see ourselves as technologically isolated.
So a big part of, or a consistent theme in everything you just outlined has, if not perhaps the most frequent word used, was community. As certainly like the underlying and underpinning nature of how Montana Pediatrics works. Outside of that, though, that sort of problem, or the solutions that come with solving for things like access to care, really for anybody, is arguably through establishing a community, ultimately to the end of having consistent and easy communication across the various providers and interests of this community. One of the really fascinating, and certainly one of my favorite things about the Connected Care platform, is the capacity for it to maintain a system of record for the purposes of that sort of communication. But one of the sort of lingering aspects of that I see personally in managing the product every day is the fact that that was established sort of as one of many responses to the potential lack of access to simply an internet connection, where perhaps it might not be possible or ideal enough to do just like a telehealth session. So even for a parent or another provider to be able to pull something up by way of a truly collaborative system, like a collaborative interface, to look at something and consult that, and not have to start from scratch every time when going to see like a different provider, like literally having something you can print off. Mm-hmm. That is the summarized version of the history of, in this case, you and your kiddo, so that when you walk in the door, you're not presented a question like, so, what brings you in today? And your head drops in your hands like, okay, well, in 2012, we started, and you have to break into this whole story. And given the circumstances of, yeah, you're staring at your child and you're like, what is happening? You're not really in a great place to recount the details of a situation, particularly insofar as to give a physician enough information to start from accurately. So all of that said, knowing that communication is key as part of establishing these communities, knowing that there really hasn't been another platform like this that solves these problems through these ways. Can you list any examples you've seen in the past, or like trends of examples of things you've seen in the past where that kind of communication has played out in a way that confirmed your suspicions that whether it's telehealth or whether it's just by way of documenting things, that it helped people, it helped a certain situation go from what it would have been without Montana Pediatrics, or what it would have been without Connected Care, but what it was instead?
So many, and different components of what you're talking about. Communication, trust, right, which becomes a part of communication, validation of the communication. So I think Kate and April probably have some really good experiences that they can talk to you about what it's like to interact with providers, to talk about Montana Pediatrics, and for them to talk about why it's different to be a part of Montana Pediatrics and to have this capacity to participate. And I'll let them talk about that because they work with the front desks. They work with how do we actually close the loop on what happened to children overnight and what is going on in your clinic and how deeply important that is to the providers. So I'll let them talk about that. I will say there are no end of sort of patient-facing stories that are fundamentally, I don't know any other telemedicine program other than just like your own doctor who happened to get on a video chat who already knows you that could have seen the kids that we see and could have had the great outcomes that we have had because of the way in which the community is facilitated at the level of Montana and is facilitated at the level of these providers and has the capacity for communication across those settings. So some of those come in the lessons of available information, and some of those come in the lessons of information that we already know because we have local connections that that anyone else would not have had. So those stories come in everything from very non-complex kiddos whose parents absolutely would not have trusted any other telemedicine, but they will come to Montana Pediatrics because how they know about Montana Pediatrics is from their own doctor. And they know that their own doctor is able to both tell us about the child that we see, and we will make sure their own doctor knows exactly what happened to them at night. So that might come in the form of really simple things. I'm thinking of a tiny little 2-month-old who had 2 doctor parents. But your own 2-month-old always throws you for a loop. And there's no way the 2 doctor parents were going to go to a rando telemedicine doctor in the cloud to get a question about their own 2-month-old. But it was because this was by, with, and through, and they trusted that what happened would go back to their doc. Any patterns would be detected, so they came. We also have much more dramatic stories of kiddos who, some states we don't even have children who are on home ventilators or trachs at home. We have kiddos from home who come to Montana Pediatrics. And they know that they can actually be seen, the providers can do that level of care, that we will have enough close follow-up with their providers the next day that what happened will not be lost, and that will actually be a progression forward in their care journey. But I do think, Mike, it'd be interesting for Kate and April to talk specifically, not just about the patient experiences that are fundamentally different, but what it's like to interact with providers and to try to build out both the technological and relational opportunities for there to be seamless communication, which lays the foundations for complex care coordination opportunities.
I can go. And I will say, if I get cut off in the meantime, it wouldn't be a webinar without or about technology without somebody having tech challenges. So I'm having Wi-Fi challenges. So if you lose me, April, you hopefully get to speak while I'm not frozen on a really unflattering frame of my face. So one thing that I think is really interesting when you look at the communication aspect among providers and then among clinics, and I'm actually going to reframe this a little bit into the after hours component, is there's a clinic that we've worked with that wanted to put the workforce and of their own clinic, I should say, a little higher up the totem pole than they normally are, I should say, in terms of work-life balance or work-life harmony, and opted to connect with us about covering their after-hours call, and loved the idea of a call where the notes and the communication of every single one of their patients was routed through their front desk first thing in the morning, and then trusted that communication enough to actually no longer even have an option for families to have a phone call in the middle of the night, and trusted the telemedicine and trusted the ability to have a video call and trusted the providers on the other end of that video call. And so to have a clinic come together and say, we trust the quality of medicine that's being delivered in the middle of the night through this organization so much that we would rather route our patients through them in the middle of the night than have us take a phone call. We'll circle back with them first thing in the morning. And then what's been really interesting is around the sense of building community, of building your provider community too, where they feel not only supported at night, but now that clinic has taken extra steps to expand their daytime hours so that they're more available to families before work, after school, after work, so longer daytime hours. They've opened up a few hours for immediate walk-in care. And now they're in a pilot phase right now, but they're no longer working on Fridays. So they're giving their providers and their clinic staff this work-life balance that's not, I think, very typically seen in a clinic setting, without really having impacts on patient volumes, while still realizing a higher patient experience. All because of this sort of circle of trust and circle of communication that's happening between the Montana pediatrics providers, the clinic providers, and then the ability to share notes and then have those notes for complex kiddos, or have the notes around, you know, whatever is happening in the middle of the night, be living at this patient level where they're always accessible. And from the communication side, what's really interesting too is, Mike, to your point of, or maybe it was Chelsea, of it's, you know, you're talking about your young kiddo and you're trying to remember what everything's happened since 2012. Typically, parents are not the medical experts and they're not remembering all of this specific detailed level of care. And so being able to house that kind of information in a setting that follows the patient wherever they go all the time and can bring in multiple providers, it's been really cool to watch and see and watch it in action as clinics and families are really growing and sort of leaning into this innovative space.
Yeah, and I would lean in and just say, to piggyback on what Kate said, what's even neater is the fact of the spirit of collaboration that this was born out of, and actually seeing providers who are part of these clinics that we partner with participate in taking that call, and once in a while they get to see their own kids that they see as a PCP. And that was the whole idea of this collaborative model of like-minded physicians and providers. And so when they're up in the cloud and they're seeing all these kids from across the state, we're seeing more instances of them actually getting in front of their own patients overnight, which is a really neat thing to see, and really speaks to the integration and embedding in the culture in the individual clinics, because through that mechanism, these providers become practice champions for Montana pediatrics inside of their clinics, and they can speak to their colleagues and nurses, and then you get that really seamless front office to back office communication to all patients at the same time, telling the same story and advocating and trusting us across the board. So it's really cool to see.
Yeah, definitely. And from what I've seen also, especially in the way that in aggregate, the way that patients and providers use the system, that use the connected care platform, it's by way of the fact that so much of this is occurring within the state of Montana as a truly rural state. It is like all of these arguably disjointed physician offices that might not otherwise be communicating, but Chelsea, to your point, straight up by virtue of their willingness to do better in the world, were willing to jump in together all at once. But nevertheless, like on the whole, or in general, these are smaller provider offices. But when you lump them all together as one thing and eliminate or at least minimize the challenges that come from geographic isolation or just purely distance, you're really starting to solve for huge problems that exist for folks in rural communities, regardless of what state they're in, or even the nature of geographic isolation or financial isolation, which sort of brings me to when we're putting together these systems of communication by way of relationships, it's almost like you're creating this virtual hospital that doesn't sit in one place. It's just sort of kind of floating all over the place. And it looks more like this, like a box of other boxes with people's faces on them. And that is leveraging, of course, leveraging technology in a way that the Jetsons didn't really predict all that well. On the long list of things the Jetsons didn't get right. I don't know why I always come back to that. I think a lot about the Jetsons. So anyway, I suppose my point is, when it comes to the alternative, instead of a patient or a provider interacting with patients, like to your points of allowing for better flexibility, just simply greater sanity and greater trust in sharing information. What have been, again, some of the alternatives seen in the past when it comes to problems with geographic isolation, problems with financial prevention from people seeking care, when it comes to just like actually going to a hospital, going to an emergency room, or even going to an urgent care? In lieu of doing those things, assuming someone in a rural community even has that option, what are some ways that Montana Pediatrics or the platform has helped solve for that in ways you haven't seen in other solutions or other ways?
Lots. That's a big question. There's a lot of problems in healthcare. So you throw it out that way, you can sort of pick your perspective and pick your poison.
Have at it.
Yeah, pick some poisons. So, we could do some real fundamentals, right? There's not enough providers, and there are going to be fewer and fewer providers sort of on a per capita basis in the right places to provide healthcare. So when you have an absolute scarcity in something, we have to look for more efficient ways to use the resources that we have. So whereas other telemedicine solutions were not about finding latent capacity within the community, they were just about competing or beaming in or building entire sections in the cloud, or alternatively just making it so that I could answer a call with a video instead of a phone. Nothing has fundamentally changed at that point. We can't just afford to scoop off providers and make cloud-based systems that compete with our existing systems. That's a tragic endpoint for the quality of healthcare in most of America, not even rural America. So like sort of separate cloud-based competitors, not a good endpoint. Just putting me giving me a video instead of a phone, or forcing people to park in my parking lot may have some efficiencies, but ultimately not fundamentally a game changer, right? So the game changer capacity of Montana Peds that has addressed some of these fundamental scarcity issues is this idea that we're looking holistically at the resources that are available and finding ways to utilize those resources, and by resources I mean qualified providers who care about their communities, in a way that serves everyone better. And I don't think I see a lot of other solutions out there that make that possible. I can do telemedicine, you can beam in and compete with me, but I don't see anyone marrying that. And that, quite frankly, that problem was the one that however many years ago when I had the misguided decision that like, we just need our own technology platform that builds collaboration, that was the one I couldn't find anywhere. And I spent a year looking, and I'm not sure anyone, I know there are other people like who have that idea, but we haven't encountered anything that quite solves for the latent capacity model. So that's one. So fundamental scarcity. Healthcare also just sucks as a consumer, as a family. It's a terrible experience. And so anything that we can do to not make you sign 57 forms when one would do, anything that we can do to make sure that all the information that is needed is gathered in the moment of the time you're going to seek care, but in a way that doesn't obstruct you getting to the provider. Anything we can do to make this not what it's like to log into most EHR portals and more of what it's like to shop on a consumer-facing technological experience, then that's on us, right? Because healthcare has fundamentally just been so interested in their own experience that they've been less interested in designing around the patient experience. And people give a lot of lip service to that, but I don't see a lot of places, again, where patient experience is driving the core systems of a given region's experience as much. We often see that as sort of the vending machine model of medicine. If your hair is falling out, or you're having trouble with erections, or you're worried about fertility, or like, have we got a telemedicine solution for you? Put your quarters in here and out will pop your prescription. Not good for healthcare, not good for longevity, not good for prevention, not good for local systems. Like, there's good for some things, but so fragmentation is something that we've seen worsened, and this is something that's trying to counter the concepts of fragmentation as well. Fragmentation is a horrible customer experience at the end of the day and leads to bad outcomes. What else? What else are we solving for, guys? Some of the things yeah, go.
Oh, I was just going to say, one of the things that's really interesting, Mike, when you were talking about, maybe if this didn't exist, what would a family do? And we just took a more recent peek at our numbers, and it's about 80% of the patients that we've seen would have gone to an emergency room or an urgent care. So when you were talking about financial scarcity, that's hundreds of thousands of dollars that have stayed in the pockets of families here in Montana to be reinvested in the community, reinvested in the economy, but in a way that's still supporting Montana's own healthcare economy too. So it's kind of a win-win on both sides. And one of the pieces that I think is really interesting and disheartening maybe about the state of Montana, there's no freestanding children's hospital in the state. A severe lack of pediatric providers in most counties across the state, but no real specific pediatric emergency providers too. So even if you're hitting the ED, you're not necessarily getting pediatric specific care. So you're still incurring this high cost. And with Montana Peds, you're not incurring a high cost. You're able to stay at home and you're getting ped specific care and supporting, right, a Montana based organization and Montana's own providers too.
Right, and to take that even further from the perspective of the providers, think about you're a brand new rural provider in a 25-bed critical access hospital on the prairie of Montana, and you just got out of school because that's the only way that you could get your loans repaid. There's all these programs, and you get out there and you have absolutely no support. You are on your own, you're on the prairie. So imagine the ability of an organization to partner with somebody like Montana Peds, and it becomes a huge recruitment tool for providers to accept positions in these rural areas where it's traditionally extremely difficult to recruit medical professionals to, knowing that they do have this backup of pediatric specialists, and it just really does make a difference through the lens of the providers out in the middle of nowhere trying to provide care to a small community as well. So really stretches beyond the family experience and even the system experience, and it gets into the pocket of the actual provider, feeling tucked in their own environment.
Mike, if you have some burning question, cut me off, but I have one more thing I was going to say. Okay. From the patient experience perspective, and I think it's actually the outlying provider experience perspective, I think that's one of the other things that we have not found that we could get from anyone else at this point, which is this idea that fundamental to the way the technology facilitates the community is that while on the back end, it's facilitating this repooling of providers to respond to the right folks at the right time, it doesn't put that burden on the patient at all. The patient gets to experience not only a single starting point for their care, right? Digital front doors have become very in vogue since I started this. I didn't know what that was, but it is a single digital front door for patients, but it's not, we don't even make them all walk through the same front door, which I think is actually, we haven't seen this type of generosity to the patient experience available, or we haven't been able to do this anywhere else. So I'll give you an example. If you are an outlying critical access hospital and we're working with your community and your kids need care, we will give you a starting point that's reflective not only of who you are. So you might be on the Highline of Montana and you get to go to Highline Kids or whatever, I should probably say a real URL, Kate can tell me, and you get to come in and how you're accessing care makes sense to you. Behind the scenes, it's probably the same doc who is also covering a different setting, but your experience of how much information do we need from you? What do we already know about you? How much do I have to torture you for a credit card? Like, all of that is customized to what we already know about who you are by that starting point. And if you want to contrast that to some terrible experiences of seeking healthcare, it's in its own ballgame. So another example of that for us would be our work with a community that cares for very young mothers who have children and they don't have family supports. And so these are wraparound services for really adolescent moms. When they come to seek healthcare, the same awesome Montana pediatrician can care for them as someone who's coming from Big Sky Ski Resort on vacation who has a question about their kid while they're traveling in Montana. But how we want to interface with you, how we want you to feel we're welcoming you into this environment is completely different. And that's the beauty of what we're able to do. So that mama can get us on her phone. We don't have to ask her about insurance. We have a relationship with the organization that she works with. She has a streamlined opportunity to just hold her hand up and say, help, I'm worried about my little one. And we don't have to put any barriers between the provider and that experience. Now, you're at the Yellowstone Club and you're coming and you need a visit, like, we're probably going to ask you for your credit card and we're going to ask you for your insurance information, and you're going to have a life experience that makes that pretty easy, and that's going to keep our costs down, and we don't have. So I guess I just want to also say, I think one of the really unique things we've been able to do is not just, again, like virtualize healthcare, but we've been able to take advantage of the fact that your digital front door is like literally your couch, and the degree to which we need to torture you on the way in when you are worried about your child, like literally my prototype person was, you're a mom, it's midnight, you're being vomited on. Can you get to the doctor? We've been able to continuously try to improve and customize that experience, which again is really, really rare in healthcare that we even have that ability, but or that focus. So anyway, sorry.
No, that's extremely helpful and valuable. Working For me personally, the thing that brought me to Vine was knowing that Vine Medical was starting to shift its interests in its participation in the healthcare industry to start moving more toward the patient experience. For me, where I came from prior to Vine was, the long and short of it is, I saw the end result every day. I saw the end result of the whole journey, starting with the patient interaction, which is where Montana Pediatrics sits, all the way through their experiences with multiple providers, multiple interactions, surgeries, denials of coverage, and the way that I saw it, the way that it was delivered to me and the things that I had to manage was by way of records of prior authorization and claims. I saw the credits of everyone's movies, and didn't like a lot of what I saw. And so when I did see that, Vine Medical, as a company that has traditionally existed downstream from that, for sure. So for me personally, that was a good thing, because I wanted to get closer to the kitchen and closer to those problems rather than just kind of watching them play out. Vine's decision to basically ride on the coattails of everything that Montana Pediatrics has set up, to me, was a massive opportunity, not just for me, but also for Vine Medical. When we look at the history of Vine's customers, when we look at larger hospital systems and the sort of, deeper into the chronological order of just orders management in general, to oversimplify it, that's further upstream, that's further downstream from the interactions between patients and providers. Because yet again, we're dealing with more of the records of that, but more as they're happening actively. What's super cool to me is that we, like Vine, we now have the opportunity to help providers, and not just, and I do mean providers like smaller offices, like I mentioned before. That's a new world for us. And so to be able to think about those types of problems, but through the lens of knowing what those challenges are, and my words, the dysfunction of healthcare that we see and try to solve for already, to get into a position of, all right, we still see the manifestation of dysfunction and the things that hospital systems and their related providers have to deal with. So what can we do to help them by going way, way further and ideally getting in front of and improving the patient experience right where the thing starts? And it's uncharted territory for Vine Medical, for sure. But again, personally, I consider myself extremely lucky to be a part of that. Vine Medical benefits massively from the work that Montana Pediatrics has done in this regard, because you, every day, and I again consider myself very, very lucky to interact with you as closely and as regularly as I do. You got in front of that patient experience and also thought about providers, and you thought about it as one thing ultimately. And that one thing was all basically a means to an end. And the end is okay, is being okay. If healthcare is the supply of being okay, the demand is the okay. And you're solving for that. And you're solving for it under what I think are the most emotionally and financially sensitive circumstances. You're dealing with pediatrics, you're dealing with geographic isolation, you're dealing with isolation by way of financial barriers. You've already been solving for what the healthcare industry as a whole, we're talking 320 million people in the US, what the healthcare industry considers to be an edge case of a particularly complex nature, that perhaps there isn't a one size fits all, solution. And Vine has been given the gift of operating off of that assumption from which you started, which to me is the underpinning of everything really we've talked about and that you've described today, particularly around how there isn't an existing solution out there, and it's to solve for these types of problems, and you started that. And so Vine is lucky to be a part of that now, and to be working with you, Montana Pediatrics, every day to further solve that problem and see how we can solve those problems together with more providers in the future, and being further upstream in those patient-provider interactions. Then as we track that, chronologically back into the place where Vine has always kind of existed, and having an impact on the start so that we can improve the end, which is where Vine Medical's always been. So with that, I do want to say personally and on behalf of Vine Medical, thank you so much for everything that you do with us and that you do for your community, and also for hanging out here today. So this has been really great, even though I did talk to you yesterday, and that was also great, always. So Jen, I don't know if I am usually the culprit for these things, but Jen, I know we do want to have some time for Q&A. So I think we could probably start that off. Oh, we've got a, here is a question from the audience. So the question is, what policies or initiatives have been successful in improving rural healthcare access and outcomes, and what lessons can be learned from them? A question from the audience.
Wow.
It's a very big audience question.
Yeah, it's a good one.
It is a great one. So there's some underlying policies that obviously are important that we've benefited from in Montana. I often quote one of our old senators, Conrad Burns, who is a Montana Republican senator, who whenever I'm writing about this, we say, Conrad Burns said there was a lot of dirt between light bulbs in Montana, and we say that's still true. But we have some foundational policies in Montana that we hope continue around telemedicine being of value and being paid for. So obviously, depending on where our listener is from, it needs to be something that is paid for. And that is in flux in the United States right now, but the public health emergency certainly elevated telemedicine as a concept. But like we've talked about, sort of just doctors can video conference too doesn't necessarily lead to anything of meaning. And so I think some of the things that are our values and our policies internally are that when we go to engage with providing healthcare in a community, we see it as a way to build up the resources of that community and not an extractive industry. I think a lot of what we see with healthcare beaming out from centers is that they're going to beam into a community and they're going to see some patients, but the end game of that is so they are pulling referrals into their systems, they're pulling dollars into their large environments the way that they bill. So we have a policy around which, when we're engaging with a community, a tribal community, or an entity that is under-resourced, that our philosophy is to make sure that our benefit is shared with them. And so it becomes about capacity building in the rural community at the same time as it is about the delivery of expertise. And ultimately, the delivery of expertise is dependent upon the capacity of the community to be the telepresenters to pick up where people are sick. And so anyone who treats healthcare in a rural space as if they can just extract dollars through interactions will ultimately not, in the long game, have a successful model, because if they just decimate the local resources for healthcare, they will no longer have an appropriate platform to deliver their expertise. So that is a deeply held sort of component of what we do, and something very different than what we've seen even in our own state around how people consider the delivery of resources. I think I talked already about no group of humans that need healthcare can be treated with in the same exact way. So what is it that, who do you need beside you? And what is the digital front door to accessing care? We treat each community in each setting differently. And that's, when we talk about rural America, do people need access from their home? Do they need it from the one little clinic in town? Is it from the school? Should we put an access point in the basement of the church, the bar? I don't know, pick your point. But we don't assume that when we walk into a community, we know what it means for your community to access care, and we try to build out those resources as well. So I don't know if that answers, it's a start to the question. But we're about delivering expertise that support our community, and I think every single component of that is built around that, and that has made us very successful. The ways in which we are able to contract our revenue sources are stronger than any of our counterparts doing this type of work, because we're willing to partner with the local communities, and we're willing to jump through any hoops that are required to be a part of the community and not a competitor with the community. There are often better reimbursement rates in rural environments or specific contexts. We can be a part of that if we're patient and we partner with them. We will, and simultaneously benefit the community. I'm gonna stop talking. Next question, someone else. April, Kate, answer. What else do we do? Rural policy.
Well, I think the rollback of the PHE obviously has some impacts, but it has also created enormous efficiencies, which I believe will continue. And we're very fortunate to be in Montana right now with the way that the legislature is looking at the rollback of the PHE. So we keep our fingers on it, and we're watching it consistently, but a lot of it's still up in the air for right now. So.
Well, I think that's a pretty good place to wrap up, because we are at time. But once again, I'd like to thank you for your time, and the audience. Thanks for hanging out with us today. But for me, and I think I speak on behalf of all of Vine Medical, we really appreciate and are honestly inspired by the hearts run over with mercy at Montana Pediatrics, and how, you're blowing a bugle that no one's heard, and you truly do take care of your own. And we're very fortunate to work with you and to witness that every day, and to do it through the platform that we work on together, Refine Connected Care, because it all funnels through that. And so that is what Vine Medical is working on these days. So thank you again for your time, and thank you everyone for hanging out with us. Really appreciate it, and happy Wednesday.
Happy Wednesday. Thank you, everybody.